Yes, this is an important question. So we have actually two options. One option is using targeting another pathway for CLL, that's the BCL2 pathway. So the option there would be with venetoclax based on the Milano study. That's a fixed duration regimen for 2 years. But then a more recent option is instead still targeting the BTK pathway, but with a different mode of action, of actually a different mode of binding with the non-covalent BTK inhibitors. And the one that we know best is at the moment Pirtobrutinib, for which we have several clinical trials already available. And this is something we have to think of it as a different, really different mode of action compared to the covalent BTK inhibitors. The covalent BTK inhibitors target a specific cysteine in the BTK molecule, but instead the non-covalent, like Pirtobrutinib, they establish different type of bonds, and so they are functioning also in patients with mutated cysteine. And I think that safety is always a priority, especially because the CLL population tends to be an elderly population with a median age diagnosis 72, median age first treatment 76. So it's important, and these patients have many comorbidities. So thinking of safety is very important, and the non-covalent BTK inhibitors have a very high and excellent safety profile, and we know that from several clinical trials, including the recent blind 3-to-1 study that compared, in fact, in patients relapsing after covalent BTK inhibitors, compared Pirtobrutinib versus investigator's choice. The rate of atrial fibrillation was very marginal, so very good safety profile. Efficacy is always important also, and we don't have head-to-head comparisons between the two different options that we have. But with non-covalent inhibitors, we can also guarantee a very good efficacy to the patient.